Hello, hello. Yeah, okay, thank you.
So I have,
Sure.
I have a flight ticket. I think Friday morning the attendance is normally the lowest in terms of the attendance.
That's fine.
Yeah.
Okay. Okay. All right, great. Thank you.
So you guys all know Dr. Chen from Wednesday, and she's going to continue to talk about treatment of congestive heart failure, right? I'll see you guys next week.
Okay. So good morning. It's quite early. I live in Long Island, so I left my house at 6 o'clock and I rushed to get here. So it took me 2 hours. So my days already have been started like quite long ago. So so I understand that the last lecture that I gave was quite difficult. I mean, in general, even as a pharmacist or pharmacotherapy specialist, anti-arrhythmic medication is still a very difficult topic to understand. And so for you guys, just knowing the basic, I think it should be good enough. I read your review books and, I try to highlight what you guys need to know. But, if you guys have any questions and things like that, feel free to ask me, send me an email. And if a lot of students have the same questions, then I will just send the answer to Dr. Yang, Dr. Yang, and Professor Yang, and he will send it out to the rest of the people. But if it's just one or two students have a question that is a very specific question, then I will just answer to you guys directly. Okay, so today we're going to talk about the pharmacotherapy of heart failure, and this is actually a easier to understand topic, but heart failure is become one of the very common disease states with a lot of patients now, so it will be interesting to know. Okay, all right, so this is my objectives for today. The first portions of my lecture, I will talk about chronic congestive heart failure, and the second portion is acute decompensated heart failure. But I will focus more, right? So the second portion will be very short, but the first portion will be longer because this has the most medications that you guys most likely will encounter patients on those medications. Okay. So heart failure is defined as acute, let me just get a pointer out. Okay, so heart failure is divided into two major categories: acute decompensated heart failure, acute heart failure, or chronic heart failure. And chronic heart failure also defined as right heart failure or left heart failure. Okay. And majority of the heart failure is left heart failure. And why is so important? What does it mean by left heart failure? Left heart failure is really defined as something wrong with your ventricle. And as I mentioned in the past, ventricle is the biggest chamber in your heart, and that supply the most oxygen, or really supply your cardiac output, your total body blood that supplies oxygenated blood that's supplied to your whole body. So left heart failure also divided into two types of heart failure. One is called diastolic dysfunctions, or in other words, now the terminology has changed in the recent guideline, is called heart failure with preserved ejection fraction, okay? And or systolic dysfunction, which call it as heart failure with reduced ejection fraction. So the main therapy is really treating a systolic dysfunction of heart failure, okay? And why is that, right? So a diastolic means when your heart is relaxing, okay? Versus systolic heart failure is when the heart is squeezing. So there's something wrong with the squeezing. right? So squeezing meaning that how strong your heart is pumping is by, in other words, is your systolic function. And how much your heart squeeze, it determines how much blood that is pumped out from the ventricle to supply blood to the vessel or rest of your vessel in your body, right? So it's determine your cardiac output almost, right? So it is determine your cardiac output. So in order to, so that is that. So what causing left heart failure, right? So what causing this chamber, this is the biggest chamber in your heart that in a failure state. So obviously, if patient have cardiac arrest, right? So if they have myocardial infarction or myocardial ischemia, if patients all of a sudden have cardiac arrest, that can causing the muscle dying and ultimately lead to a failure state. If patient have volume overload, right? In any situation that causing volume overload, that causing the heart has a lot of fluids like that's in your body and in your heart that cause your heart not able to pump, and that can causing heart failure. If a patient has high blood pressure, right, that constantly causing this high blood pressure that ultimately will, or pulmonary hypertension, that or stenosis, that ultimately when your heart is pumping so hard, so fast, against a lot of resistance, and ultimately it wear off, right? So it's just almost like a machine that when you're overusing a machine, when you're causing so much resistance, so much friction, ultimately your heart is going to fail. Okay, so before we really understand the pathophysiology of heart failure, I need you guys to know some of the terminology, right? And a lot of time it's just in abbreviation. So cardiac output, what does it mean by cardiac output? Cardiac output means a volume of blood that ejected per unit time, okay? So meaning that how many heartbeats per minute, right? And so how many, how do I say, the volume that is actually pumped out from your ventricle, pretty much, that's it. So what exactly is cardiac output meaning is that each, the volume that ejected in each beat of your heartbeat or your ventricle plus, right, times the hour. So in heart rate, meaning that how many heart rates per minute? Okay, sorry. So how many heart rates per minute? So let's say I have 60, my heart pumps 60 beats per minute. Each beat, how much volume in that beat? So the cardiac output means that in 1 minute time, how much volume that beats out from that or pump it out from that ventricle, it determines your cardiac output. Okay, so stroke volume mainly just means how much volume in that one beat, okay, one heartbeat. Preload means the pressure that find in the ventricle at the end of diastolic, meaning that what pressure that is maintained at the end when your heart is totally relaxing, right? So, so let's say your heart is able to pump it this big, right? And whatever that pressure, right? If the bigger the pressure, the less of the volume that you'll be able to pump it up. So you're usually able to relax, right? Like very totally relax. And now if I have a lot of pressures in your it's almost like a balloon, right? So if you have like very thickening of your wall, and you have a lot of pressure, you're causing a lot of pressure, your heart be able to pump it this big, right? Smaller. And so the amount of blood in that chamber will be less. So a stroke volume is determined how much blood in that chamber at the end when the heart is totally relaxing. Afterload means the pressure against when the ventricle is ejecting blood, right? So if the pressure is very less, right, you'll be able to pump into the chamber very easily, right? But if you have a lot of, in the beginning, when the heart is able to, when the blood is pumping into the heart, if in the beginning, right, in the beginning, that's against a lot of pressure, that means not a lot of blood will be able to go into that chamber, all right? So it's the ejection, right? Because if they're against a lot of, right, against a lot of resistance, obviously, you're not able to pump a lot of blood in that chamber. Main arterial pressure means that is a cardiac output times systemic vascular resistance, okay? So that pressure, usually we want to maintain like more than 65 and things like that, right? So we always talk about MET because that will tell you how well that your blood, your heart is able to pump. If your pressure is like, the main arterial pressure is like 30 or 40, then probably that will be not very good, right? So ejection fraction, so that is another concept that is very important to know. Ejection fraction is really determine how well your muscle is able to pump, okay? Normal ejection fraction is about 60 to 70%. A heart failure patient means that the heart is able to only pump 40% of the blood, okay? And so either is like your heart is just not able to have the contractility, right? It lost the elasticity almost, that is not able to pump out. So it's a function, it determines the function. So a lot of time when people say, oh, this person has a heart failure, that person has heart failure, you really have to determine what is the ejection fraction of the heart. And the ejection fraction is 40, we call it as the beginner of of a heart failure. So for you and for me, our ejection fraction most likely will be 50 to 70, and that is normal. If a patient has 40, we call the beginner of heart failure. When it's less than 30, we start to say, what, this is pretty severe, right? So when it's 30, we really worry about a patient, okay? All right, so I talk about diastolic dysfunction and systolic dysfunction. So literally, like the systolic dysfunction is ultimately is telling you that patients have decreased ejection fraction, okay? Because it's when the heart is squeezing, how much it can be squeezed, okay? All right. So exactly what is a heart failure? Heart failure means a decrease in heart's pumping capacity, as I mentioned to you. So when it decreases the pumping capacity, when the heart is not able to totally squeeze the heart, then that means that it has inefficiency of cardiac output, meaning that your cardiac output will be decreased, right? You're not able to fully pump the blood up from the ventricle and filling the body, so your cardiac output will be decreased. And so why you think that will happen? What causing it? Is actually a compensatory response. So what does it mean? When your body senses that, oh, I don't have enough of blood pumping out from the heart, it could be that, oh, all of a sudden the patient has a cut vessel that is no longer able to supply the heart with enough blood supply, or any reason, that when the body senses, I have a decrease of cardiac output and I have to do something, because if I have decreased of blood supply to the body, I need to help increase that cardiac output. So what they do is they increase the preload, right? They increase the preload. They help the squeeze in order increase the stroke volume. They cause vasoconstriction, right? Increase that squeeze by vasoconstriction, increase the blood vessel pressure to help increase the volume, right? Increase cardiac output. They increase tachycardia because I told you cardiac output equals stroke volume times heart rate. So if they sense that there is not enough of stroke volume, then they have to increase the heart rate, right? to increase the heart rate in order to say if I'm making multiple more heart rate, in the way I will increase cardiac output. So when your heart is, when your body is trying to maintain cardiac output by increase heart rate, increase pressure, increase your blood pressure, trying to do all this thing in the beginning, isn't that good? Because it's true, it will maintain cardiac output, right? But ultimately, when your body is, when your heart is keep doing that, as I mentioned before, the heart is going to fail. The muscle is not able to maintain 100 beats of heart rate constantly because it usually working at 70 or 80, right? Your blood pressure usually is 120, 80, 120 over 80. Now your blood pressure is 180, right? By constricting the vessel and increase this pressure, pumping the blood into your ventricle. Yeah, ultimately, your heart is like, I have too much stretch. And when it's stretched and nowhere to go, what I'm gonna fail, right? So the greater the stretch, in order to increase the cardiac output, meaning the more forceful contraction, it will, what it will do? It will increase stroke volume. But then when the stretch is excessive, the ventricle will dilate. It will just, okay, I can't pump anymore. And ultimately, it decreases ejection fraction, meaning that then ultimately, when your heart muscle is like, I'm dying, I'm just not able to pump anymore, I cannot contract anymore, what happened? It will lose that force to ultimately pump the blood out from the ventricle. So it will decrease the ejection fraction. You decrease that capacity of pumping out the blood and supply. So it's a vicious cycle in a way. So that means that when this excessive response, when it becomes a long term, it will lead to a complicated functional biochemical and molecular changes that initiate the cause of progressions of heart failure syndrome, right? Okay. So how the body increase preload? So now we understand that, okay, so we know that in the beginning is okay, but when all this compensatory response in the beginning is okay, but we don't want the heart to overdoing it. So how does the body by increase a preload to maintain this cardiac output, right? They usually do by increase preload. But how exactly is through by increased sodium and water retention. And by increased water and sodium retention, they ultimately optimizing the stroke volume, helping that 1 beat of blood volume in the blood in the per beat of your heartbeat or per pump, like increase that volume in there. But then ultimately it can causing pulmonary and systemic congestion and edema formation. They also causing vasoconstriction, right? Ultimately increase the cardiac output by increasing norepinephrine, angiotensin II, endothelium, and arginine vasopressin. What do? Those are vasoconstrictors, right? Increase the pressure, increase that force getting into, pump the blood into the chamber. And ultimately, it can also causing a lot of detrimental effect. Tachycardia also, as I mentioned, increase the heart rate to maintain the cardiac output. But ultimately, it also, if overdoing it, it will causing detrimental effect. So a lot of medication is by going say, okay, so I know the heart is overdoing all this 1, 2, 3 like mechanisms. So I will targeting those mechanisms, right? Inhibiting all those norepinephrine, angiotensin II, endothelium, they are vasoconstrictors. So I'm going to prevent I'm going to blocking those too much of vasoconstrictors. I'm going to decrease the sodiums and water retention by causing eliminations of sodiums and water retention. If the heart is pumping too fast, I'm going to decrease the heart rate, right? So all those medication is going by all those mechanisms. So here we go. So when the body sends a decrease of cardiac output, it will activating the sympathetic nervous system. What does it do? It increases norepinephrine, endothelium, and vasopressin by causing vasoconstrictor in order to maintain cardiac output. It also activating or stimulating the renin-angiotensin systems by increase angiotensin 2 and aldosterone. And the angiotensin 2 and aldosterone, they are also vasoconstrictors, okay? And so that will also try to maintain cardiac output. The body also has two very interesting mechanisms. When they sense that the body senses that it's like I have decreased cardiac output, it will release an inflammatory cytokine like a TNF alpha. And what does it do? It is an inflammatory cytokine, and it will further causing heart failure, okay? But then also there is another mechanism that sense that, wow, my body is trying to do all this compensatory effect by activating the sympathetic nervous system and the renin system, and they are overdoing it. So I need to balance it out, that effect. So they also release another enzyme called vasodilatory peptide, which is the AMP and BMP. And so they are the natriuretic peptide. And what they do is actually they vasodilate it. They say, you can't do too much of vasoconstrictor, and I need to vasodilate it a little bit. I need to help you like get rid of all these sodiums and water that you try to retain. So your body is actually try their best, right, to also maintain this balance. But in many times, you know, those but many times they cannot very equal out, right? So the activations of sympathetic nervous systems and renin system, they are very strong. They're just overdoing it. So no matter how much of those vasodilatory peptide that they produce, is still not able to like really calm them down. So a lot of medication, they come up by inhibiting the all this norepinephrine, endothelium, or angiotensins blockade, but at the way they agonizing or they produce or they help to produce more of the vasodilatory peptide. So that is all this medication, the mechanisms behind all those medications. Okay. So ultimately, the role of medication in heart failure is to reduce the vascular assistance, reduce volumes, maintain the force of contractility, right? Not the heart is failing, the muscle is not able to contract. So they maintain, but they don't, they're not overexertions, meaning that they don't pump too much, but at the way they don't, they also do not decrease the contractility. Okay, so angiotensin 2, as I mentioned before, is by increase the systemic vascular resistance, increase the angiotensins, increase the norepinephrine, and increase the vasopressins. They also increase the sodium water retentions, and ultimately when they are overdoing it, they can causing ventricular hypertrophy. Your heart is lost pumping, it becomes thickening, it becomes too much water build up around the heart, and ultimately it can causing self-death. Norepinephrine ultimately can causing tachycardia, causing vasoconstriction, increased contractility, and also ultimately will causing hypertrophy of your heart and also apoptosis or like self-death. Aldosterone, another very strong vasoconstrictor, that causing volume overload, right, by maintaining sodiums, waters, retentions, and ultimately will also increase and will cause problem. And as I mentioned to you about the vasodilatory peptide, is called neutral irregular peptides. And what they do is they increase the eliminations of sodium, diuresis, they're causing vasodilatation, they decrease the aldosterone's release, and they are trying to balance, right, the overdoing of the sympathetic nervous system and the renin system. And the other one is arginine vasopressins. And they are usually the vasopressin, right, the vasoconstrictors, we call it, is actually have two types. Vasopressors is another strong vasoconstrictors. Vasopressors receptor 1A is causing the vasoconstrictor and increase cardiac contractility. Vasopressins receptor 2, it reabsorb free water, right, but it decrease sodium retention. So in general, a medication will focus of antagonizing the vasopressins 1A receptor. Okay, so I talked to you a lot about this background, how heart become failure state and things like that. Not necessarily, I don't need you guys to memorizing it, but it's just really helping you to understand how medications work and helping you to say, I don't just memorizing it and say this is, to just really rely on your memory, but really understand that, this is how it works, and so I'll be able to, know the effect of the drug. So ACE inhibitor, right? I will talk about ACE inhibitor, angiotensin receptor blocker. They are blocking the angiotensin 2, right, by causing vasodilations, eliminating sodium, waters, retentions, decrease blood pressure. Beta blocker inhibiting norepinephrine by decrease the heart rate. Okay, aldosterone receptor blocker, which is another class of medication, is blocking the aldosterone, which preventing too much of vasoconstriction. And tolvaptan and canivaptan, they are already antagonizing the vasopressin 1A receptor. And the nicerotide, which is the analog of your body's neutral irregular peptide or the vasodilatory peptide. Okay. So what are the symptoms that associate with the left ventricular dysfunction? So patient is going to constantly have this volume overload. Patient's going to have tachycardia. And so ultimately the heart isn't able to pump. So what happens is the patient is going to feel shortness of breath, right, when they are on exertion. They are orthopnea, meaning that when they lay down, they're going to have shortness of breath, all this fluid in their heart, in the lung, is really pushing, causing the heart not able to pump, the lung not able to expand. They have tachycardia, they have dry cough, they have fatigue, they feel dizziness, they feel dizzy, they have these symptoms of fluid retention. The fluid can be high in the abdomen, in the peripheral area, in their leg, in the lung. So you're gonna you're gonna have this abnormal lung sounds due to the all this fluid. You're gonna have abnormal heart sounds. You're gonna hear all this fluid that is hiding in your heart, in your lung, and in general, patients that has ejection fraction less than 40%. So heart failure has 4 classes, and that is based on the New York Heart Association's heart failure classification. Class 1 means that the patient does not have any physical activity limitation. Ordinary exercise does not causing undue fatigue, chest pains, palpitations, or dyspnea. They might have some sign like edema and things like that, but it doesn't really affecting, or their ejection fraction might be like 40%, but it doesn't really, they don't really feel much when they are doing physical activity. Class 2 is slight limitation on physical activity. They feel comfortable at rest, and ordinary exercise, they has a little bit of palpitations and things like that. Okay. Marked limitation is class 3, that they have marked limitations of physical activity. They might be comfortable at rest, but when they are less than, even they used to be able to walk like 10 blocks, now they walk like 3 blocks, and they start to feel like shortness of breath and fatigue, chest pain, and things like that. And then class 4 is the most severe class, that is like even when they're resting, when they're sleeping, when they're sitting down, they start to feel like very shortness of breath, and they are not able to carry any like normal physical activity. Okay. So the class will kind of telling you how severe, right? I mean, the class, it does tell you how severe the heart failure is. And it will also kind of tell you what medication to give to these patients. So heart failure, you kind of wanted to prevent from a class 1 to class 2 to class 3 to class 4, and then ultimately lead to death, right? So for patient that has class 1, in general, we want to start with 2 medication, okay? So ACE inhibitor or ARB, or angiotensin receptor blocker, and a beta blocker. Okay, so ACE inhibitor or ARB and a beta blocker. For patients that have signs of volume overload and is in class 2 to 4, you can start it with a loop diuretics. Okay, so ACE and ARB is the first drug that you need to give it to all patients. And then when it's class 2 to 4, and they have symptoms of volume overload, you want to give loop diuretics. For patients who have persistent symptomatic issues, and they're African Americans, and they are falling into a class of 3 to 4, like a more severe. So African Americans with class 3 to 4 of heart failure, you want to start with hydroxyzine and nitrates. That's a combination drugs, or you can give it that separately. And then for heart failure class 3 to 4, you wanted to, and with the creatinine clearance not less than 30, and the potassium is okay, less than 5, you should start with the aldosterone antagonist. As we mentioned last time, that aldosterone can, spironolactone, right? Aldosterone antagonist like spironolactone can causing renal failure and can causing potassium, like high potassium. So you need to initiate it when the renal so those type of patients, if their renal function is dysfunction and their potassium is more than 5, we usually don't want to start with aldosterone antagonist like spironolactone. But if they are good, if they're okay, and they're in class 2 to 4, you should start with this medication. Okay. Yes. So, so not necessary, right? So, and I will go over like later. So, loop diuretic is just ready for symptomatics, right? To just get rid of the water, but it doesn't helping the whole process of like this, the response, right? The neural, the hormonal like response. So in the long run, it does not improve mortality, but it actually helps with the symptoms, right? So if the patients, you can see signs of edema, if you hear their lung sound, they have this lung sound that's suggesting the lung has fluids in there. If they have shortness of breath, if they have edema, you have ascites, then yes, you start, patient will feel much better, but so that is really just for symptom, okay? So yes, it's not necessary you have to, but if patient has the symptoms, you will start. Okay. So the treatments for heart failure, and why we already have to we want to talk about it, is that heart failure you wanted to prevent from one stage to the other stage, right? You want to improve their quality of life by not constantly feel fatigue and shortness of breath. So improve quality of life. Reduce symptoms, reduce hospitalization when they're not able to breathe, when they are constantly, in all these symptoms. Ultimately, they want to go to the hospital. They need to go to visit physicians. So reduce hospitalizations, slow the progressions of heart failure, right? Preventing from one stage to the other stage. And then ultimately, the most important thing is that it prolongs survival. So if the patient said, I'm okay, I think I'm just going to do exercise or like doing like some, I don't know, like something to like, ultimately, it can lead to death, okay? So giving all this medication is really helping them to survive longer. Okay. So let me go into the depth of heart failure. So all this is really just introductions. So for you guys to understand how medications work, why we need all these medications, right? We give medications, always have to have an indication. And so all this drug is by targeting all this over-exertions of response or over-exert responses from your body's that your body is generating in order to maintain cardiac output. So we wanted to kind of slow down a little bit. So ACE inhibitor, angiotensin II receptor blocker, right, antagonize the angiotensin system. Hydroxyzine and isosulfides, right, beta blocker, aldosterone antagonist, diuretics, and digitalis. Digitalis is digoxin. Under the class of digitalis is actually just one drug, digoxin. In the past, some people say, is it two drugs? What is digitalis? Well, digitalis is actually really a plant. If you go to like all this botanical garden and things like that, sometimes they say, don't touch that plant. That's digitalis. Well, yes, digoxin is actually a plant, and when kids touching and things like that, sometimes they can get like absorptions through skin, maybe, I don't know, so not much, so for me and for you might not have much effects, but maybe for babies, kids, they might have some, they can decrease their heart rate and things like that. So anyway, so let's go into the first drugs, right? So ACE inhibitor, ARB, beta blocker should be giving for any heart failure patients, meaning that any class of heart failure patient. So ACE inhibitor is working by, so angiotensin is a vasoconstrictor. Angiotensinogens is converted to, so angiotensin sinogens, right? Angiotensin sinogen, did I say it wrong? Angiotensinogen. Angiotensinogens, right, is the most potent vasoconstrictor. It converted into angiotensin 1, and then angiotensin 1, right, converted into angiotensin 2 by angiotensin ACE is like converted into angiotensin. Angiotensin 1 converted to angiotensin 2, and then angiotensin 2 is the one that you actually is causing the vasoconstrictions, is releasing aldosterone and vasopressins, and they all are vasoconstrictors. So all this has to be converted by an enzyme, right? So angiotensinogens converted into angiotensin 1, right? And then another enzyme convert angiotensin 1 to angiotensin 2. And angiotensin 2 is really the receptor, or that causing the release of aldosterone and vasopressins, and by itself can causing vasoconstriction. So ACE inhibitor is really an enzyme that is inhibiting the conversions of angiotensin 1 to angiotensin 2. And you almost can think that like angiotensinogens is a prodrug, right? Like a pole, like it is just there, it's a molecule there. And you need to convert it into an active mechanism or molecule, and which in this case is angiotensin 2. So to prevent these conversions of become an active molecule, in the way, just for you to understand, you need something to blocking it from conversions from angiotensin 1 to angiotensin 2. Okay, so ACE inhibitor is prevent that conversions. So also, your body also in a way has a bradykinin, okay, and bradykinin is a vasodilator, okay. So ACE inhibitor also have another function that inhibiting the degradations of bradykinin. Bradykinin is a vasodilator, so it's a good thing. So in a way, ACE inhibitor also have a functions of inhibiting the degradation of bradykinin, and that will causing vasodilatation and helping a further vasodilator. Okay. So ACE inhibitor should be given for all patients unless it's contraindicating or intolerance. They decrease vasoconstrictor response, they improve symptoms and exercise tolerance. They reduce remodeling or progressions of heart failure. They reduce risk of MI and sudden death. They reduce hospitalizations, and they decrease mortality. And most importantly, it decreases mortality on average about 30%. Okay, so I do need you guys to know about some of the side effects with ACE inhibitor. Okay. Oh, actually, let me before I go into. Okay, before I go into side effect, what are the ACE inhibitors? So I need, as I mentioned like last class, I need you guys to know the class of a medication. So what does it mean? If I say enalapril, right, you need to know enalapril is ACE inhibitor. And it's easy to know this the drugs because they all end with pril, right? Captopril, enalapril, lisinopril, lisinopril, quinapril, rinapril, all end with pril. So you know they are ACE inhibitors, okay? So that's all you guys need to know. I don't need you guys to know the dose. I don't need you guys to know the the duration, the maximum, like those, anything like that. Know the name, that what those drugs, which class is those drugs belong to. Okay, so I need you guys to know some of the common side effects associated with ACE inhibitor. It can cause chronic cough because that bradykinin is a vasodilator, right? It usually easily be degraded, right, to break down. But now ACE inhibitor prevented it from breaking down in the way that bradykinin can causing dry cough. So now your body has more bradykinin, and that causing dry cough. Okay, so ACE inhibitor, it can causing dry cough through that mechanism. It can worsen renal function, right? It causing vasodilator of your kidney vessel. So because it dilates the vessels, there's less of the blood is retained in your kidney. So your kidney is hyperperfuted and causing renal function. So with that, I just, try to get you guys some idea. So anyway, so you need to know that ACE inhibitor can causing dry cough, can worsening your renal function, can causing hyperkalemia, can causing angioedema. What's angioedema is the swollen of the lips, of your throat. It could be life-threatening, because if your throat is swollen, you can't really breathe, right? And so it can causing those side effects. Okay. All right. So whatever I highlighted here, you kind of have to know. All right. So this is a study that just to help you know, like about like how ACE inhibitor works and things like that, and what the clinical trial has showing about ACE inhibitor. So I don't need you guys to memorizing study. So this is in general, a lot of clinical trial, you talk about hundreds of patients, 200 of patients, but in this kind of study, it's like a big number of patients, which is good, right? It's very good. So this is about 2,500 patients that is in this trial. And so one group, they divided into two groups. One group receiving placebo, which we don't know what medication those are, or maybe no medication, and the other group of patients receiving ACE inhibitor. And they follow up those patients a long time, almost 42 months. And what they found is that when compared with placebo, ACE inhibitor actually has about 16% of reductions in risk. And ultimately, that risk is actually death risk. Okay, so the additionals of enalapril to conventional therapy significantly reduce mortality and hospitalizations for heart failure. Okay, with patients with decreased left ventricular ejection fraction. So, in average, among all this, so they do like meta-analysis, and then they do like average, and it turned out to be that ACE inhibitor by itself can decrease mortality about 30%. So in this study, 16%, that's one. But on average, it can actually decrease mortality by 30%. Angiotensins, and I will go faster, and I promise you, the second portions of my lecture will be very short. So angiotensin 2 receptor blocker is almost doing the same thing as ACE inhibitor, except that when angiotensin 2 converted to angiotensin, when angiotensin 1 converted to angiotensin 2, it's not the whole receptor, right? It's not the whole angiotensin 2 that causing vasoconstrictor. It actually has two receptors. One is angiotensin 1 and angiotensin 2, angiotensin type 1 receptor and angiotensin type 2 receptor. And underneath the angiotensin 2 type 1 and type 2 receptor, the type 1 causing vasoconstriction. The type 2 actually causing vasodilator. So ultimately, this drug is focusing in these portions of the receptor. So angiotensin receptor blocker is by blocking the angiotensin 2 type 1 receptor, okay? And so this type of drugs ultimately doing almost the same thing as ACE inhibitor, it is more specific. ACE inhibitor is more specific, but it does not have an effect on bradykinin. So that is pretty much the difference. Okay, it does not prevent degradations of bradykinin. And why I mention about that is that because it does not causing degradations of the bradykinin, ultimately this drug do not cause cough. So a lot of patients, I have seen a lot of patients cough like nonstop with ACE inhibitor. So in this way, we just switch them to angiotensin receptor blocker. So angiotensin ACE2 receptor blocker is it is an alternative for those alternative to ACE inhibitor for those patients that symptoms are not able to tolerate ACE inhibitor. It decreases the same percentage of mortality and decrease hospitalizations as much as ACE inhibitor. They reduce, they improve exercise tolerance, and they improve quality of life and ventricular function. But you cannot give both together, okay? There is no add-on, right? Because once you give two type of drugs together, you actually, two class of drugs together, you can actually causing harm. So what are the drugs that are called angiotensin II receptor blocker? They are candesartan, losartan, valsartan. So how do you know? They end with sartan. They all end with sartan. Okay, so if you know, sartan is ARB. Okay, so quickly just going over the case, you know, when they add candesartan with the patients that has heart ejection fraction less than 40% and actually not able to tolerate ACE inhibitor, and after 3 days they found that angiotensin receptor blocker can decrease death and hospitalization by 23% based on this study. And they see the benefits when the patient is on or off beta blocker. So in a way that is a true effect from the angiotensin receptor blocker, okay? So, so that's ACE and ARB, right? So the second class that I'm going to talk about is the vasodilators, which is the nitrates and hydralazine. Nitrates is the vasodilator, and hydralazine is also a vasodilator. One is venous, one is arterial. And so they ultimately will decrease the resistance, right, systemic vascular resistance, and ultimately increase stroke volume and cardiac output. And nitrate will, because of vasodilator, it protects against myocardial and vascular remodeling, right? So that's what we want in terms of slow down the heart failures progression. And hydralazine is actually preventing, it has another effect. Besides the fact that it's a venous vasodilator, it also protects the degradations on nitric oxide, okay? So in general, the combinations of drugs together, it decreases about 40% of mortality in African Americans. So why I say that? So there's a clinical trial looking at ACE inhibitor for all comers, for all patients. And it turned out to be surprisingly, Caucasians population of patients responds to ACE inhibitor more than African Americans. And so somehow African Americans is not really benefit from ACE inhibitor. And they also has a lot of angioedema that associate with the population. So they take a look, and then they actually do another study that is actually studying with hydralazine and indoor, or like the nitric oxides. And it turned out to be, they found out that like the, in African Americans population, they are tremendously like has mortality benefits with these drugs, about 40%. So not to say that ACE inhibitor and ARBs should not be given to African Americans. It still works, right? But in those patients that are not responded as well as Caucasians population, you need to, you might just switch to this drug, okay? Because this drug, in these populations, it does show that benefits, okay? So, also that is this study is about. The classes end at what time? 9:50? Okay, all right. So, all right. Okay, so so that is that study has showing, right? So this is a study for African American and showed that for heart failure trial, and it has showing that it has a lot of benefit. Beta blocker, and the study is just for you guys to know that, you know, those are the evidence that have for the clinical trial and show those drugs. So once again, I just want to emphasize that it is important for those drugs that improve mortality, right? It is important for patients to be on those drugs that improve mortality. So ACE inhibitor ops improve mortality. Hydralazine and isosulfide combination improve mortality. So next is beta blocker. Beta blocker, right, is working by inhibiting the beta-adrenergic stimulations by blocking the beta-1 selective receptor. And it inhibiting the stimulations of norepinephrine by decreased heart rate, right, by decreased heart rate, by decreased the progressions of heart failure. Beta blocker show to have anti-arrhythmic effects, slow down the heart rate, and it reduce mortality, about 34% on average among all the studies. And it reduce hospitalizations, improve symptoms with long-term use, and reduce sudden death. So you can understand why it's so important, that why all heart failure patients need to be on either ACE or ARB and a beta blocker to wait from the beginning of a heart failure state. Okay, so there are three main drugs that is actually they are being studied and has shown that it's beneficial in patients with heart failure, not the other drugs. So bisoprolol, covadolol, and metoprolol succinate. Okay, I need you guys to know these drugs as beta blockers. So all end with OLOL. Okay, and okay. So some of the side effects associated with beta blocker is low blood pressure. Right, it can causing not much, but low blood pressure can cause diarrhea, bradycardia. They can causing some, you know, when the blood pressure is low, when the heart rate is low, obviously you're going to feel dizzy, fatigue, depression. They're contraindicating for a patient that has a heart block because they're already inhibiting the pumping, right? As yes, 2 days ago we talked about inhibiting the AV nodal pumping, right? So to lower the, but if the heart, the AV node is already blocked, right? It already have heart block, then those patients should not be further been blocking those nodes. Okay, so they're contraindicating for those effects. All right. So there is a study looking at, so when I talk to you guys about metoprolol succinate, they are the extensive release beta blocker. So that is a metoprolol succinate, a tartrate, which is a short acting. We're usually giving as Q12 hours, Q8 hours. But I'm only talking about the extended release formulation of metoprolol. Why? Right? So there is a study that compared the short-acting, there's a study looking at the long-acting beta blocker, which is the succinate formulation. And it turned out to be that metoprolol succinate or extended release formulation improve mortality in heart failure so well, right? So good. So it has this very beneficial effect. So the conclusion of that study is that once daily metoprolol succinate can reduce mortality by 34%. Okay, and the dose that they give actually in that is actually they target at 200 milligrams daily, which is the highest dose in that study. So they give the metoprolol extended release, giving that maximum dose, and at the end of the study, they found out, wow, this drug does work and decrease mortality. Okay, what's your question?
Yeah, I'm sorry, is it only metoprolol or any beta blocker?
No, right, only metoprolol I'm talking about. Metoprolol is a beta-1 selective beta blocker. So the study is looking at the extended release of beta blocker or metoprolol. So the extended release of metoprolol and turned out to be have mortality benefit. So people said, well, then let me study other drugs, right? Has beta blockade effects, maybe is better than metoprolol. So yes, so that is a COMET trial, and they compare the coferidolol with what drug they compare to? Metoprolol tartrate, the short-acting beta blocker. And so they conduct a study, right? And the maximum dose that the metoprolol they give is what? 50 milligrams twice a day. And as I mentioned about the previous study with the extended release metoprolol, what was the target dose that they used? 200 milligrams, right? So that is the difference. So then the endpoint is mortality and composite endpoint. And they found out, wow, coferidolol is better than metoprolol tartrate. So wow. So the manufacturer company say, I'm going to promote the use of coferidolol over metoprolol, right? So they immediately coferidolol. So does coferidolol work? Definitely, right? It works. So then the critique of the study was that, wait a minute, you do not compare with metoprolol's XL. And that is the drug that shows improved mortality. The original study, the MERIT trial, did not compare the short-acting to beta blocker. It's comparing the long-acting. So that is one critique of that study. The second critique was, hey, wait a minute, you're using 50 milligrams twice a day. You do not using 200 milligrams daily. You did not maximizing the dosing of metoprolol. So therefore, it's apple and orange. Therefore, the conclusion is this. For heart failure patients, we can use coferidolol. Yes, the clinical trial showed that it works. We improve mortality tremendously. And you can using metoprolol XL as well. We do not suggest you to using short-acting. If the patient has heart failure, you should using metoprolol XL. And they're equally beneficial as compared to coferidolol. Okay, so that's it. So just to let you guys know, and to answer your questions, is not all beta blocker, right? It's not all beta blocker equal the same. It's those three drugs that has a clinical trial that's showing that it's good for heart failure patients. Okay. Do you still have questions? Okay. So aldosterone antagonists is another group of drugs which we're initiating. Originally, the heart failure chest guidelines suggest for class 3 and 4. And ultimately, they've done a lot of studying showing, wow, the early initiations of this drug actually has a lot of benefit for patients because aldosterone is a very strong vasoconstrictor. So therefore, we should start it when patients starting to have class 2 heart failure. So this drug is indicated for all patients that has class 2 to class 4 heart failure if they are able, they are not contraindicated to do it. So as I mentioned to you, aldosterone retains sodium, retains water, and it's a vasoconstrictor and things like that. And then so spironolactone and epinephrine usually is the two drugs, main drug, as to antagonizing the aldosterone. Okay, so the effect, the clinical effect is anti-aldosterone and decrease of fluid retention, anti-arrhythmic effects, and prevent the fibrotic effect, meaning that it prevent the heart muscle become fibrotic. Okay, so usually we should consider for class 2, 3, and then 4 if they're not contraindicated. Again, this group of drugs decrease mortality. It has a potassium-sparing effect, right? And so there's two drugs usually been using is the spironolactone and the epirolone, and they make it very good, right? Because then you say all end with O, right? O-N-U. So this trial again, there is study on the spironolactone, and they found that the patient has a very good and has a lot of benefits of in terms of mortality. Okay. So in conclusion of this study, spironolactone reduced risk of death from all causes, death from cardiac causes, hospitalizations for cardiac causes, and combined endpoint of death from cardiac causes or hospitalization for cardiac cause among the patients with severe heart failure due to left ventricular systolic dysfunctions on standard therapy, including ACE inhibitor. So this is more like an add-on. So patients on ACE inhibitor based on beta blocker, and by adding on this drug, so when patients had starting with class 2, it shows tremendously of improvement, of further improvement. So it's a good drug to start. So there's a lot of new drugs recently for heart failure, and it just kind of modify whatever we have and this and that. So yes, so so the concept is the same. I do not include all the drugs out there, the new drugs, okay? But I include this drug because this drug you can see in the commercial as well. They are done so much commercial on this drug, and this drug is called angiotensin receptor neprilysin inhibitor. The name of the drug is called Entrasta, and I don't know if you guys heard the commercial. I saw it like so many times. So it's a class 1 recommendation, meaning that it's a very high recommendation from the guideline to replace an ACE inhibitor or ARB with a ARNI to further reduce mortality and morbidity in selected patients. So if the patient has chronic symptomatic reduced ejection fraction heart failure, class 2 and 3, and with good blood pressure, who are already tolerating a reasonable dose of ACE inhibitor or ARB, it can actually, so the patient is already an ACE and ARB, right? But they still have very persistent symptoms of heart failure. And so by switching this drug, the ACE inhibitor and the ARB, by switching ACE and ARB into this drug can further decrease mortality and improve symptoms. So how does this drug work? This drug is a combination of an ARB, so it's already an ARB, so that's same thing as and a sacubitril. What is sacubitril? Sacubitril is an anti-lipid license antagonist, right? So what is a neprilysin? Neprilysin degrades vasoactive peptides such as neutral elliptic peptides and bradykinin. We talk about our body has this very good peptide is causing vasodilator. It's called neutral elliptic peptide, right? We mentioned it before. And they also have bradykinin, which is causing vasodilator, which was in the degradation of bradykinin was inhibited by what? By ACE inhibitor. And so, which is good, but it's not inhibited by ARB, right? So this drug is adding a drug that preventing the degradation of a neutral elliptic peptide and bradykinin. So isn't that benefit? So yes, so this clinical trial, just there for you guys to read, to know that after this trial, this drug is actually getting FDA approved, and and it's good, right? It's on market, and it just came out like recently. Okay, so so some of the safety profile. We know valsartan can cause hypotension, renal insufficiency, angioedema, same as any of the. Sacubitril is, as we mentioned before, right, that we have it break down the bradykinin, prevent the breakdown of bradykinin, and prevent the breakdown of the neutral urea peptide. It can, so angioedema can be caused by ACE inhibitor. So this drug can further causing angioedema. So it's 3 times about ACE inhibitor. So you are like think, well, why this drug is not combined with ACE inhibitor, but it's a combination of R, right? Because ultimately that lipsin, like the effect is almost the same as ACE inhibitor. It's just more, right? It's just more. So you can't really give a ACE inhibitor with the lipolysis like drugs, right, or anti-lipolysis drugs in order for it to work. Otherwise, it will have tremendous of side effects. Just hold the thoughts for a second. So therefore, if a patient that is on ACE inhibitor, it will say that it has to hold the dose of 36 hours. You let the ACE inhibitor's effects eliminate it first, okay? And then you add on this drug. Because otherwise, patients gonna have dry cough, patients have all this more side effects of the ACE inhibitor, more so than the ACE inhibitor by itself, okay?
Yeah, I'm sorry, these drugs, what exactly are they? Are they ACE inhibitors, or are they?
They're not, right? So what are they? Right, as I mentioned before.
Well, there are.
Right. So they are what? They're a lipolysis inhibitor, right? So what does lipolysis do? It prevents the degradations of the peptide and bradykinin. So the degradation or the breakdown of the bradykinin and the peptides, which they are the good thing, right? So ACE inhibitor does not prevent the degradations of the peptides, but it does prevent the degradations of bradykinin, right? So in the way, this drug has an additive effect, meaning that it can helping for vasodilations, not only through the bradykinin, right, but also has through the natriuretic peptide as well. But because it also prevents the degradation of bradykinin, just like ACE inhibitor. So if you give the ACE inhibitor with this drug together, it just can profoundly causing more of the side effect that can be caused by the ACE inhibitor. Is that okay? Yeah, is understood. Okay. So loop diuretics. Loop diuretic is just for fluid. We talk a lot before and things like that. And it's an add-on, as I mentioned it to you. It's the add-on. It's just for symptomatics. So it reduces symptoms due to fluid retentions, pulmonary congestions, improve quality of life, and it decrease hospitalization. But it do not, decrease the progressions of a disease and also prolongs a survival. So this drug does not, but doesn't mean that symptom quality of life is very still important, right? But it's an add-on, it's a combination. It should not be just a monotherapy for patients has heart failure. Okay, so some of the problems that we mentioned about last time with loop diuretics and things like that is for you guys to see and understand. Okay, so and we talked about yesterday about all this the day before about the loop diuretics, right? So the bumetanide, torsemide, furosemide, and then many times we also add on the distal tubules inhibitor, right? To the drugs that are inhibiting the sodiums, potassiums, and water reabsorption in the distal tubule, like the hydrochlorothiazide and metolazone, for it to increase the effect of the loop diuretics, as I mentioned in the last lecture. So yes, so those drugs many times we start with loop diuretics, and if the patients are really still not able to eliminating all those extra water fluids in their body, we add on the diazide-like or diazide diuretics. Okay, so digoxin. Digoxin is actually become a not so commonly used drug. I mean, in your textbook, they still talk about like digoxin, which is, in certain population is still very important. And so what does it do is that it inhibiting the sodium potassium to ATP pumps, right? So what does it do is normally we have 3 sodiums pumping into the heart, 3 sodiums pumping out from the cell, 2 potassium pumping inside the cell, and so this is inhibiting this pump, and so in the way that this is how it works, right? But this is work, and in exchange, they also by inhibiting this pump, the exchange they can have increase of calcium influx into the heart, and that will increase contractility. So this whole mechanism is really about what? It's about like this drug does decrease heart rate, but it does not decrease contractility. So in a heart failure patient, what does it mean? The muscle is not able to pump. You don't want to give a drug that further decrease the pumping effect or the contractility. And this drug, it can help decrease the heart rate, but it does not further decrease, right? But it actually increased the tone a little bit. So it has a positive inotropic effect. It has increased contractility. And that's all you need to really know for this drug. So any drug that increase inotropic effect is really the digoxin itself. Digoxin do not improve mortality. It does not, it just slowing the ventricular rate, okay? And it decreases hospitalization. It has a positive inotropic effect and increased vagal tone. And vagal tone means that it just decreases the heart rate, okay? So for patients with impaired systolic functions and class 2, 3, and 4, and they are already on beta blocker, and their heart rate are still not being controlled, and they're on 200 milligrams of metoprolol succinate, and their heart rate are still not being controlled. So you will consider the digoxins on it, because calcium channel blocker like cortisone and diltiazem, as I mentioned it in the last lecture, they have what effect? They have negative inotropic effect. So for heart failure patients, you don't want to further decrease that tone, decrease that contractility. So in general, if you have a patient that has on metoprolol already, and the heart rate is not being controlled, you don't want to add on those cortisones and diltiazem, but you consider to add on this digoxin drugs. And that's pretty much it, right? So we talk about like it has a narrow therapeutic index and things like that last time. So that is that. And so, the side effects that we mentioned last time, same thing, right? Nausea, vomiting, diarrhea, those you need to kind of think about it. And so this is, this slide is really just, for you to just FYI, but you don't really need to know about this. They don't even talk about this in your review books. So I think that one take-home message is that digoxin is a part of heart failure drugs, and it has a very it has all the side effects, and it has positive inotropic effect. And I think that's 3 main things that you really have to memorize with this drug. Okay, all right. So this is just a diagram, of like the conclusions of all these drugs and how this drug work, and so for you to further understand how these drugs work in different systems. Okay, so I can either, so 9:30 now. I have another 10 minutes because I need to give you guys a break. So I can finish the last portion in 10 minutes, or you guys can take a break. Finish. Okay. So acute decompensated heart failure, okay? You don't really need to know like details or what class, what this and that and whatever. But I read your review book. They just named some of the drugs there. So I highlighted it for you to know. Acute decompensated heart failure is for those patients that have chronic heart failure and now they have massive symptoms. They just massive symptoms and they just not able to live their normal daily life. And ultimately, so what precipitates acute decompensated heart failure is many patients. The majority of the issue is patients are not compliant with their chronic heart failure medication. Some of the toxins can causing it. All of a sudden, patients have acute MI can causing it, but mainly it was just patients or patients are taking too much sodiums, eat a lot of sodiums, and or drink a lot of fluids, and ultimately tend to maintain more fluid and things like that. So those are some of the mechanisms. So presentation is volume overload. That's the first sign, and then they have not only volume overload, they have low perfusion. So now they have a lot of, their heart is not able to pump anymore in severe heart failure. So what happened? When they have no, they are not able to pump blood out from their ventricle, or their ventricle can only pump out this little tiny volume of blood in their heart. What happened? Hypoperfusion. So when it's hypoperfusion, they're going to be very cold extremity, right? Your extremity is not providing with all this blood. So they are usually just presented with volume overload, and they are present with hypoperfusion. And hypoperfusion is much worse, right? A symptom or sign than compared with volume overload. And you're not going to see this type of patients in your daily practice because these patients usually come into the hospital and need immediate treatment. And so what do they do? So that's symptoms quickly I want to mention is that, congestive heart failure, usually we say warm and dry is the best, right? They're warm, they still well perfused, and they're dry and not very bad. Profile 2 is warm and wet, so they are still perfused, they're still able to perfuse their vessels, but they're wet, so what they need is really diuretic, right? So if they're cold and dry, okay, so I need a little bit of vasal inotropic drugs to pump some blood into your vessels. And so they're actually still okay, right? But then if they're cold and wet is the worst, right? So they're not perfusing and they are wet, and those are, we call it as cardiogenic shock. They're severe shock right now. So that is that, right? So it tells you what drugs that you need to give, right? You either give vasodilator to help perfuse the vessel and also have further helping with the diuresis, or you're giving a inotrope if the blood pressure is low, because now your blood pressure is so low, you are like not able to perfuse your vessels. So I need to increase your blood pressure by helping pump the blood to your periphery, to your vessels, to your heart, to your brain, right? So the goal of treatment at this point, when patients are in the shock state, is really not like, in the long run, I want to improve mortality, right? You really need to save life at that moment. So you wanted to improve signs and symptoms, and then you're optimizing the chronic oral therapy. It could be the patient are not taking the oral therapy or not compliant with the oral therapy for the chronic heart failure, or they are just, the drugs are not optimizing it. Maybe they need to add on another class of medications. They are not on it, and things like that. And we need to maybe switch the ARNI, right? Switch ACE to ARNI and things like that, okay? So mainly when the patients are coming with the acute decompensated heart failure, what do we do? The first thing that we do is most of the time they present with volume overload. So we give loop diuretic drugs, right? We're giving IV, and then we just giving IV, and we see if the patient are responding to it. We can start it with just injections and intermittent injections. And if the patient are really not responding, we can do as infusion. But the study has shown the injections versus continuous infusion in the ER setting when the patients are first admitted, it didn't really have much of difference. So yes, but we do not give up PO anymore, and then we just do it at IV. Okay, so that's that. Usually we give very, very high dose of loop diuretics. People say, oh, it can cause ototoxicity, meaning that then the hearing loss. It's okay. I mean, it's not that it's okay, but at this point, patient is dying, right? So we need to increase that loop diuretic to help eliminating all the sodiums, all this water in the body. Okay, so when the patient is not still on the fluids, we manipulate the therapy, we give loop diuretics, we give diuretic, and patients are still not able to have a full benefit of or eliminating the fluids. What do you do? So we add on another drug, is vasodilators, to help with the almost like help the diuresis effect. If the blood pressure is okay, I need to add on those vasodilator to help, of diuretic effect. So what are the drugs in there? So all you need to know is that nitroglycerin, nitroprusside, and nicerotide is the 3 vasodilators, a systemic vasodilator that you can help with increase the diuretic effect. Okay, and so that those are the 3 drugs. The main therapy that in the market is nicerotide. Okay, and we're using nicerotides. And in your review book, it talks about nicerotides as a vasodilators. So you just know the name, okay? And knowing that because it's a vasodilator, what we do? It will decrease blood pressure, okay? This is ready for the effect of diuresis. Okay, so for those patients that has low perfusion, what do? You cannot give those vasodilator anymore, right? Then you need to, so patient with a low cardiac output symptomatics hypotension, then you give inotrope, so Mioron or dobutamine. Dobutamine is quite frequently used, and Mioron is also, Mioron can causing hypotension, it can causing reflex tachycardia as an outcome of it, but it increases the contractility, and dobutamine as well. We're using dobutamine a lot, right? And so just for you to know, for this acute decompensated heart failure, what we really need to know about this class of disease is to know that when the patient have acute decompensated heart failure, they have profound symptoms. They can have volume overload and they can have hypoperfusion. And usually we give very high dose of diuretics to help eliminating the fluids. And we can add on the nicerotides, which is the vasodilator, to help further diurese. And then if patients are hypoperfusion, we'll add on dobutamine and Mioron. So just recognize the drugs: Mioron, dobutamine, nicerotides, and furosemides, or the loop diuretics. And that's pretty much just the name, that's the concept. And ultimately, when the patients are recovering from this, you wanted to really restricting their sodium content. And in sometimes, even after all this medications, patients are still not, their heart just not able to pump and things like that. Then they probably need a heart transplant. They need like a balloon pump to help them pump but that is really like the end stage of this heart failure. So ultimately, that is my presentation. I need you guys to focus on the drugs in the chronic heart failure, knowing the class drug, knowing what drugs can improve mortality, knowing how they work is really just for you to know the drugs better. But some of the common side effects that I highlighted in the lecture. Acute decompensated heart failure don't really need too much, but then just knowing that those are the loop diuretics plus the serotypes, the mirolone and dobutamine are the drugs that using in general for the just recognize the name that those are the drugs that for acute decompensated heart failure. Okay, so that's the conclusion, and that's it. For the lecture. Okay. Any questions? You guys can come and ask me, if you guys want and things like that. But pretty much this is what what I need you guys to know, and along highlight some of the things that is in your review books, and by explaining the mechanisms, I hope that to help you guys better understand how this medications works. Okay. All right. Okay.